Now we're going to take a moment to sort of step back to the idea of pregnancy as a whole and how it is that we manage pregnancies and how it is that we care for babies when we think there's a problem. Now, I will say there's certainly a great deal of thought about the right way to manage a pregnancy and whether you even ought to be describing it as managing a pregnancy or we should consider pregnancy a normal process and we're just following along with. Not a debate we're going to have in this class. Um, Mostly our focus is on how development either normally occurs or does not occur normally, and then what we do when that happens. But to start off with, we have now hit the fetal period. So from embryonic week 8 through birth, gestational week 10, that's the fetal period. During the early part of this period, most of the organ development completes, and we see growth, although it's really more length than weight. After week 21, most of the major organs are largely formed or are completely formed, with the exception of the lungs, which continue to develop over the course of the rest of the pregnancy. And we see fairly significant growth of the baby, including the baby putting on a great deal of weight and getting that sort of chubby baby look that everybody likes. Now, this gestational age chart in your book, I thought I would point a couple things out. So they're showing this measurement calculation of gestational age based on crown rump length. That's a very standard measurement used in the early first trimester of pregnancy. Measures the length of the baby from the top of the head along the back to the rump or the rear end of the baby. And in early stages of pregnancy, it is highly consistent across all babies at the same gestational or embryonic age. It's an excellent way to date the pregnancy. If a baby has a certain length of measurement, then they must be a certain age. Okay? This crown heel length that they mention here, I've actually never heard of. I've been working in high-risk pregnancy for 12 years. It's never come up. So I don't think this one's terribly common, and I wouldn't spend too much time worrying about that one. Normally in the second trimester, when we're trying to get an idea of how far along the baby is or how well the baby's growing, we do what's called a bioparietal diameter, which is a measurement of the size of the skull. And that's the way I'm familiar with dating in the second trimester. And that measurement is shown there. Now, I will point out that these measurements are all well and good for us, people who work in obstetrics or midwifery, people who work in embryology, but in reality, the pregnant women are still thinking about their babies in terms of fruit and vegetables, so I've provided those corollaries here. Okay, what does the normal course of a pregnancy look like from a medical perspective? And again, this is the obstetric perspective. This is not the midwifery perspective, which tends to be different and include fewer things. But once pregnancy is detected, so most women discover usually at 4 to 8 weeks of gestation, they've missed their period, they gave it a week or two, take a pregnancy test. So first thing you often do is have confirmation of pregnancy. Even if you peed on a stick at home, a lot of times your OBGYN will want to confirm in their office, either with urine or with blood. Okay. They will also do your initial prenatal lab work, which includes a bunch of things. Type and screen for your blood. The type part is easy. Are you A, B, O, positive, negative? The screening is a test of whether or not you've been sensitized to any antibodies. We talked about the Rh antibodies, but there are others that can cause similar problems, and they want to know if you have any. They do a CBC, which is a complete blood count, and assessment of a variety of different factors, anemia, etc., and then testing for sexually transmitted diseases, because those can have implications for a pregnancy. By 12 weeks gestation, you've probably done carrier screening if you want it, which is testing for inherited Mendelian disorders that you might be at risk for. Aneuploidy screening, either with biochemical testing or with cell-free fetal DNA testing, depending on your age and risk factors, if you want it. And nuchal translucency ultrasound if you're doing the aneuploidy screening. Nuchal translucency ultrasound, same ultrasound. The technique is the same. It's just a measurement that you're getting. So in this picture, it's tiny, but if you look, you can see that they're taking the measurement of that dark space, which really represents the space in between the skin at the back of the baby's neck and then the musculature of the neck. And you like that measurement to be under 3 or 3.5, depending on where you're at, as compared to this baby who has what's called a cystic hygroma, where that measurement is very, very large. And if you're familiar with ultrasound, you might even be able to see that some of that extra fluid extends around to other parts of the baby. And that's a risk factor for aneuploidy, for heart defects and other birth defects, and certainly a sign that this might be a baby that's at risk of passing away before it's born. Now, next up, 16 to 20 weeks of pregnancy. That AFP screening that we talked about for spina bifida, and which may also detect gastroschisis, is usually done about 16 weeks of pregnancy. It's just a blood test. And then they do a fetal anatomy ultrasound, which is to look at the baby's anatomy, much like it sounds, usually between 18 and 20 weeks of gestation, because by that point, most of the organ systems have taken their final form, even if they're continuing to grow and develop a little bit past that point. At 28 weeks gestation, you get your gestational diabetes screening, because most women, if they're going to develop it, will have developed it by then. This is a diabetes that's caused by pregnancy. The risk for birth defects with it is fairly low, but it can produce some very large babies, and so we do like to detect it and control it if we can. For women who are obese, often they get tested in the first trimester with some of their initial lab work as well. At 35 to 37 weeks, you get tested for group B strep. That is an infection that you might carry vaginally. It's not something that's going to make you sick. You'd never know you have it. But if the baby comes into contact with it at delivery, it could produce a significant infection in the baby. And women who have it get IV antibiotics during delivery to prevent the baby from getting it. Now, the frequency of visits to your OB or midwife will increase with gestational age. Usually by the very end of your pregnancy, you're going in every week. All right, twinning. So most pregnancies are what are called singletons, one baby. But of course you can have twins or more. And twins can happen in one of two different ways. So we have dizygotic twins and monozygotic twins. Dizygotic twins are more commonly known as fraternal twins. 2 eggs got fertilized, 2 eggs developed in the mother, we get 2 babies. Then there are monozygotic twins, identical twins, 1 egg that fertilizes and at some point early in development splits to produce 2 babies. And it can actually happen at several different points. So what they're showing you in the picture here is that if it occurs at roughly the 2-cell stage, you get 2 embryonic cell masses, 2 babies with 2 placentas and 2 amniotic sacs, and it looks very much like dizygotic twins. If it happens in the early blastocyst, you can get 2 inner cell masses, but you still just have the one placenta. 2 separate membranes, 1 placenta. So these are monochorionic diamniotic twins or monodi twins. And then the last case, the splitting happens even later, and you end up with 2 babies with 1 placenta in the same sac, or monochorionic monoamniotic twins, which are very, very high risk. Now, I will point out that dizygotic twins and monozygotic twins can have dichorionic diamniotic or di-di setups. So just because twins are di-di doesn't guarantee that they're dizygotic, although usually they are. And for what it's worth, because there are some folks out there who just haven't made this connection, I thought I'd point it out. Identical twins are always the same sex. Yes, you can find something on the internet that will tell you that there's a 1 in a billion case where they weren't, but for the purposes of normal life, you can just assume that identical twins are the same sex. So if you're looking at an ultrasound and you're confused about whether or not they're identical or fraternal, and you can't tell if there's a membrane between them, if one's a boy and one's a girl, they are not identical. All right. Now, twin pregnancies of any kind are inherently riskier than singleton pregnancies. That's just fact of life. They're much more likely to miscarry, and an awful lot of times twins self-reduce to singletons on their own, meaning that one embryo dies fairly early in the first trimester, and you end up with a singleton pregnancy. In ongoing twin pregnancies, di-di twins are the lowest risk. Monodi twins and mono-mono twins face some serious potential complications. With monodi twins, you can get twin-to-twin transfusion syndrome. So normally, the blood vessels feeding one baby in the placenta should not be interacting or connecting with the blood vessels feeding the other baby. But it can happen. Sometimes it doesn't cause trouble. Other times you end up with one baby who's sending more and the other baby who's receiving more. a donor and a recipient. And that's your twin-to-twin transfusion syndrome. It's not good for either baby. The donor is losing nutrients that it needs, and the recipient has got more than it can use. Okay, I did put a link to the Children's Hospital of Philadelphia website in the module. It goes over this in detail. I do want you to read it and watch the videos. It's very helpful. A second and slightly rarer complication is twin reversed arterial perfusion sequence, or TRAP sequence. This actually only occurs when one baby is developing normally and the other baby is either sort of without a heart or essentially without a head. So the other baby is not viable, acardiac or acephalic, but still growing and developing almost like a tumor, although it may have arms and legs and sort of roughly the structure of a baby. The problem is that the viable baby, the healthy baby, is feeding that baby, and the non-viable baby. The non-viable baby is taking what the healthy baby needs, and that can be a serious complication. Although it's treated in some ways in a similar way to the twin-to-twin transfusion syndrome, you try to break off the connection between the two babies. In the case of TRAP sequence, you're of course not so worried about losing the non-viable baby. Mono-mono twins, so babies that share a placenta and an amniotic sac, are the highest risk of all. They can have complications with blood vessels connecting where they shouldn't, but they are also at fairly significant risk for cord entanglement and cord compression. So these kids, especially in the early stage, dance around in the room like ballet dancers. Their cords get all tangled up, they get knotted, and that can lead to blood flow being cut off in one or both cords. And if one baby dies, it poses a significant risk to the other baby. So these are very, very high-risk pregnancies. They're monitored very carefully. While most twin pregnancies won't make it the full length of a pregnancy, for monodi twins and particularly for mono-mono twins, you kind of do your best to get them as far as you can, and then you deliver before something bad happens, essentially, if you can get there. They're very scary pregnancies to monitor. Okay, screening and diagnosis of problems in a pregnancy. Some of this we've talked about. So we've talked about ultrasound, nuchal translucency. I will make the distinction between a fetal survey and a targeted fetal anatomy ultrasound. A fetal survey is what a routine OB does in their office. A targeted fetal anatomy ultrasound is what a maternal fetal medicine doctor does in their office. So a targeted fetal anatomy ultrasound is done in a high-risk pregnancy setting. Fetal echocardiogram, still an ultrasound, but done by a pediatric cardiologist to look at the structure of the heart. So if an obstetrician or a maternal fetal medicine specialist suspects a heart defect, they may send the patient off for a fetal echocardiogram to get a better idea of what's going on with the heart. In terms of prenatal screening, we've talked about biochemical screening and cell-free fetal DNA testing. Both screening methods for fetal aneuploidy, neither diagnostic. We talked about maternal serum AFP screening for neural tube defects. And now we're going to hit on CVS and amniocentesis. So these are invasive procedures. So they both involve going into the uterine environment to collect a sample, and as a consequence, they do have a risk for miscarriage. Slightly higher with CVS than with amniocentesis. Both of them, though, are considered diagnostic for fetal aneuploidies, for microdeletion syndromes or duplication syndromes, for Mendelian genetic disorders. Both of them, because they're getting a sample that can undergo genetic testing the way you would do with blood in an adult, they can diagnose these conditions. Amniocentesis, because it's a sampling of the amniotic fluid, can also measure amniotic fluid AFP and a second chemical called acetylcholinesterase, which does not make it into mother's blood. It's a more accurate way to look for spina bifida, and can be used in the later stages of pregnancy to assess lung maturity, to determine if it's safe to deliver or if you need to give steroids to rapidly mature the lungs. With CVS, we do run a small risk of confined placental mosaicism, meaning that the placenta has a problem that the baby doesn't have. And we hinted on that earlier. Most of the time, if a placenta is mosaic, you'll see it on the results of the testing. You can tell that there are two different cell lines, and that would clue you in that you really need to go on and do an amniocentesis and test the baby. It is rare that you don't see the mosaicism in the placenta and the baby, in fact, has a different karyotype than the placenta, but it can happen. And confined placental mosaicism will, in fact, in some cases, produce an abnormal cell-free fetal DNA testing result. It's one of the reasons that cell-free fetal DNA testing is not a diagnostic test. So how do these procedures work? Both use ultrasound guidance. This is a CVS. Now, a CVS can be done transcervically, as is being shown here, or transabdominally. Transabdominally would be with a needle through the abdomen into the placenta. In this case, the catheter is being passed through the cervix, up and into the placenta, and you're just trying to get some of the tissue from the chorionic villi. So you want the villi because they come from the baby or from the original fertilized egg. Of course, some of the tissue in the placenta comes from the mother, and you want to try and filter that out in the lab. Now, this picture is not entirely accurate for CVS because when you're doing it at 10 to 12 weeks gestation, and that's clearly not a 10 to 12-week baby. It can be done up to 14 weeks, but that's clearly not a 14-week baby, so let's just ignore that for the moment. But this is the basic idea, and you use ultrasound to sort of watch where you're going and make sure you're getting what you need. It's relatively quick, takes about 5 minutes to do, and most of the time the placenta is in a region that's accessible. Amniocentesis is done after 15 weeks gestation. It's always done transabdominally with a needle passed through the abdomen to draw off, in this case, some of the amniotic fluid. So the amniotic fluid by this stage of pregnancy is fetal urine, which means you know you're testing the fetus, not the placenta, which eliminates the concern that we have with CVS of confined placental mosaicism. It is relatively quick as well, takes about 2 minutes to do. And most women say that worrying about the discomfort was actually worse than having the procedure. So while it is a little bit uncomfortable, it's not overwhelmingly so for most people. Now on to fetal therapies. Again, not strictly speaking embryology, but useful stuff to know. And I do encourage you to go look at the Children's Hospital of Philadelphia website. We will reference it several times over the course of this class, but they are one of the premier centers in the world for fetal surgeries, which is why they have all of these resources. And when fetal surgeries are done, they're usually done as part of a research trial and or at a highly specialized center like the Children's Hospital of Philadelphia. There are a few fetal surgeries that are no longer considered research that are done more routinely, but most of them are not. And in part because there's still a great deal of risk associated with them. Some of the surgeries have the potential to produce great, wonderful outcomes for families, but may also produce no change or may actually make things worse. And it's important that it all be done in a very controlled setting and with families properly informed about what's going on. Now, this is the list of conditions for which fetal surgery can be done that's given in your book. Congenital diaphragmatic hernia is important because if you can keep the abdominal contents below the diaphragm, then the lungs may be able to develop normally. We talked about spina bifida and fetal surgeries, and you saw the module there. Twin-to-twin transfusion syndrome, it's about breaking up the connections between the blood vessels with a laser. Posterior urethral valves. So in this one, the urine can't actually exit the kidneys. And what you need to do is put a little shunt in the bladder that allows the urine to drain off. This is something that actually is done more routinely, has fewer risks and greater benefit. And this is one of the few ones that doesn't have to be done as part of a research protocol. Hypoplastic left heart syndrome is a very complicated heart defect. It is a very severe heart defect with a not terribly great prognosis for babies. In this case, they're doing the fetal surgery in some cases because if they don't, they're going to lose the baby anyway, so perhaps worth trying. But it's important to keep in mind that many fetal surgeries are not a guarantee of improvement in the outcome and may actually make things worse. But an exciting opportunity for families that want to consider it and maybe a better shot than just waiting to see what happens. Just to sort of reiterate, because this section of the book does go back to the issue of dexamethasone, it is experimental for congenital adrenal hyperplasia. And if anyone has any further questions about that, I'm happy to talk about it. The book does also mention cord blood as something that might have a lot of potential, and it is right, it is very easy to collect, but it can be very expensive to store, making it out of reach for some families financially. And there is limited data on the efficacy. So, yes, if your child gets leukemia down the road, perhaps the stem cells would be of benefit, but for most families, that isn't going to happen. For most families, the cord blood will sort of sit there for the duration of the child's life without being used at all. Now, the public cord blood banks are a nice option because then it has a much higher chance of getting used, although you may not be able to use it for your child. But there's a lot of marketing out there promoting cord blood banking to families, but not a lot of data on how likely it is to actually help. So it's one of those things where you may end up spending a lot of money and not getting a lot out of it. Now, I will say this is what I do: prenatal testing, prenatal diagnosis. This is my work as a genetic counselor. It's not the primary focus of this course. I'm sure it will be covered in other courses, but if you have questions or want to talk about it, I am very, very happy to.